We're going to move now into our provincial panels. We are going to start with our... Do we have enough chairs? If not, I will bring up an additional chair. We're going to start with our friends from British Columbia and Alberta. Kathy Barnard, president of Save Your Skin Foundation, is going to be presenting from BC. I do want to acknowledge the work of multiple people. Most provinces had working groups of 2 or 3, sometimes people. Do take a look. Their names are all listed in the back of the program, but just want to acknowledge that. And then for our Alberta, we do have multiple co-presenters, I believe. Shanil Pathak, he is a family caregiver and founder of a startup called Hanalytics, or you used to say H-Analytics. Hanalytics. Johanka McPhee, policy advocate and project consultant in the area of mental health, and Evans Yellow Old Woman, associate director of Indigenous Relations at the Alex CHC for Alberta. We want to start with you, Kath?
I think so.
All right, here we go.
For this first. Morning, everybody. I like it better when Antonella's up here because I don't have to move the mic. Here we go. Welcome to British Columbia, where there isn't snow on the ground. Just saying. I really need to thank my working group partners, Andrew and Alan, especially Alan. I have to be honest, Alan did all the work putting this together. Neither of them could attend today, so I said I would do them proud on this presentation. I'm glad we're going first. I have to tell you, Save Your Skin is part of an international group called AllCan. And this previous year, we did a patient survey across the globe on inefficiencies and waste within the healthcare systems around the globe. And there was a lot of common denominators coming back. And I noticed after we did this project, they were very similar. So I'm glad we're starting because I think we're going to probably see some of the same issues right across the country. Okay, so access to care and quality of care was our number one. So it's difficulties in receiving primary care, especially in rural areas, and those experience health inequalities. So social determinants of health among them. Those experiencing health inequities include immigrants, refugees, First Nations, and families on low income. We heard great presentations on that yesterday. Our potential and reasonable solutions, community health centers with a focus on social determinants of health by integrating healthcare services and social services, increase recruitment and training of healthcare providers across BC, telemedicine, incorporate evidence-based model into delivery of care, so for example, nurse modeling, shift from fee-based services to outcome-based payment methods, experiment with value-based payment model, payment linked to quality of care that the physicians provide, such as a pay-for-performance and bundled payment. Experiment with population-based healthcare model, payment designed to reward healthcare systems that improve the population health status. Our second one was oh my God, I can't even read this morning. Continuity of care and the patient journey. So a lack of continuity of care and siloed care with little coordination and access to other care providers in the communities where patients live. Often physicians are not able to meet the needs of those with chronic conditions. Barriers to interprovincial access to health care, services and medication due to costs, lack of, limited availability, and they're not very timely. Okay. And our potential reasonable solutions. A coordinated and province-wide approach to team-based primary and community care. So an example is the BC Primary Care Network. Universal health care, especially coverage of medication when moving from province to province. A coordinated approach to data capture and analysis across all spectrum of conditions. We have a few examples in British Columbia. Mental health. Lack of limited services to address mental health among different target populations, including patients and aging population. Our solutions: to incorporate mental health services as part of chronic disease management rather than a standalone service, introduce a new payment model into the mental health sector that links payment to health outcomes, and incorporate the patient voice into the decision-making and personalized care. We do have some examples of value-based healthcare activities in BC. They're a little outdated, I have to be honest. Hospitals in BC experimented with a funding model that looks at volume and type of patients rather than a global budget model in 2016. While the study did not alter hospital readmission rates, more studies are needed to look at payment models and health outcomes. Oftentimes, increasing health budgets doesn't necessarily mean an increase in quality of care, as no clear health outcome is established. BC experimented with case-based payment models that tie additional funding to performing additional volumes of surgeries, which showed clear linkage between funding dispersed and the results achieved. Can be used to further establish different types of payment models that link to health coverage. But that was also done in 2015. So to date, there's been no really good examples of any value-based healthcare in BC.
Hey. So I'm going to speak a bit about I'm going to start off with a bit about our methodology, and then we're going to go into some examples, and then we're going to offer it to give the mic to Evans to talk about from an Indigenous perspective on the healthcare challenges. So in terms of our methodology, one thing we found out is the questions are very broad to really roll up and answer on the perspective of the province. So what we did is we went to different organizations within Alberta just to get their opinions. And what we're going to present is not necessarily their voice, their opinion, but it broadened our lens in terms of what the issues are. And then we went from there, and we just decided to do an experiment to actually get the information and see how we could rank it. And so we did a Twitter poll, and we put our questions out there, or the issues out there, and to see what we get as a pulse check. And we had in the 3 days, 370 people who responded. And so we got some good engagement, some good comments. Now, the issue with this type of poll is it came down to the character limit of your question. So if you're ever going to do that, you have a max of 25 characters. And what happened is we were surprised that the third option there about separation of health data got ranked very low. It's supposed to be meaning but the siloization of health data. And so it could be misinterpreted, but just want to share the pros and cons of this method in terms of how do we rank our the issues. So I'm going to dive into a bit about the issues, give an example. Johanka will give further examples from a mental health perspective. So the first one, similar to what we heard from BC, is the complexity and fragmentation of our system is causing friction, and that friction prevents us to get access to the right health services that we need. The second issue is about agency and the ability to be an actor in our healthcare system. Right? If you look at it, this is my perspective, political economic perspective, but the customer has a lot of power in any industry. And who are our customers of our healthcare? It's not us, it's the government. That's where the money lies, just follow the money. They are the ones who have the power because they are the ones who have the money, and they're the ones who give the money to the providers. So the providers always look at the customer and what they could serve, what they could provide. So that limits our agency. That's my perspective. The third is about coordination and information sharing. And I'll share a personal story. So I started advocating because of my wife and her experience with cancer. And when you go through the cancer experience, you have a lot of specialists, a lot of providers, and that means there's information chaos because the information is not getting to the right person at the right time, which means the system falls onto you to fill in the gaps, so you have to repeat your story. And so that's where the burden, on top of the disease, you also have the burden of information exchange. So I'm going to hand it over to Johanka to talk about some examples.
Yeah. So in order to illustrate how we see all of this in mental health, I'm going to tell you a little bit about my story. And it's very briefly, because of time restrictions, just a very brief timeline of my journey to the system. In November 2016, I call Access Mental Health. It's a triage service in Calgary where they talk to you, they assess your situation and what service you should access. I was having issues for a while, and I got to the understanding that I needed to ask for help, but I didn't know how to start, and I didn't want to go to the primary doctor because I was ashamed. So I called Access Mental Health. They actually did give me an appointment for a psychiatrist. I couldn't afford private care, so I had to go through the system. My first appointment was January 25th, 2017. First appointment, 1 hour, is a meet and greet. When you're talking about your life and your emotions, you know 1 hour doesn't take you very far. After that, the appointments are, because they are so busy, the appointments are every 4 to 6 weeks. So second appointment, we do the assessment, diagnosis, and she says, next appointment we'll talk about options of treatment, but for now, I'm gonna put you on the waiting list of counseling because I think you will benefit by 6 months waiting list. So put me on the waiting list, March 2017. After that, the appointments with the psychiatrist are 4 to 6 weeks apart because of the workload. So we talk about treatments and options, but then that appointment, boom, hour is gone, so no prescription. Next appointment, prescription, first med. Anybody that have tried any meds, but especially for mental health, it takes a long time to find a med. So first med, terrible reaction to it. Have to stop the med. Don't see the doctor until 4 to 6 weeks after that. 4 to 6 weeks after that, another med. Same story. Fast forward, started seeing the counseling in September 2017. Did not like the counseling, but damn, I waited so long. Things were not getting better. I'm like, I better stay here. Well, what am I going to do? Can't get any worse. Well, it did. So December 2017, I have to stop working because I couldn't function. My anxiety was so high. I was extremely depressed. I was starting to react at work. I honestly thought I was going to kill my boss. So I'm like, you know what? I better stop working. It's better if I don't earn money at home than being in jail. So I'm going to stop working. So depressed, so fatigued that I couldn't leave my bed for 2.5 weeks. Okay? I'm a lucky one. I got into the system, but the system failed me. I'm better now, but I'm better because I'm stubborn as hell. I have advocacy skills. My background is legal. I speak my mind. I have a great family support system. What about the people that don't have it? And what about the people that are not as lucky as me to get into the system? Because guess what? Access Mental Health is a triage system. So not everybody gets into AHS services. Actually, a staggering percentage of the population that call Access Mental Health, because they are not mild to severe cases, according to a 25 minutes assessment on the phone, they do not refer any direct services to any official service. So they are given 2 to 3 phone numbers of community agencies to call. So pretty much they are left to their own devices. I don't know what the number is, obviously, but I would guess after you really get that courage to reach out and you don't receive anything, you leave it there. You don't continue. So we have people falling through the cracks by thousands every year. People that reach out and they don't receive the help that they need. So that's the problem. It's across health, but in mental health, that's the huge problem. So, solutions. We need a more inclusive and holistic approach to healthcare. Our body talks to each other. Like our heart and our brain, they communicate. Our liver and our kidneys, they communicate. So why don't the doctors that treat those organs communicate to each other? I mean, It doesn't sound logic to me. I don't know about you. So we need to treat the body as it is. It's an organism that interrelate with each other. You cannot see mental health completely separate from physical health because it's not. It's everything is interrelated. So we need a better approach to that. Patient groups and community agencies need to be consulting with creating health policy. It's like Chanel said, we have to be the clients, and they have to design the services taking us into consideration because we are the end users of the services. Yet, we are not consulted. We are consulted after the fact. When somebody screws up, then ask the patients, well, why didn't you ask me before you designed something which I knew was not going to work? So that has to definitely change. We have to sit at the table, but we have to have a voice at the table. And we have to have both, and we have to have some decision-making power. They have to listen to us. The other solution is private enterprises need to be allowed to participate in creating efficiencies in healthcare delivery and coordination through technology. Technology moves really fast. How often does an iPhone get out? Very fast. Guess what? So by the time the government is proposing a legislation, checking whatever they have to check, approving the legislation, 3 or 4 iPhones are out already. So the government cannot keep the pace of technology. We need private enterprises. Why? Because they can move fast, because they are more in touch with innovation, because they're shut disturbers. They can go in. Sorry, could I say? Oh, okay. Okay. Good. So that's the thing. You have to get people there that can get things done. Guess what? Sorry, government doesn't get things done. Too many mechanisms, too many things on the way. And I think I'm going to pass it on to you for the example.
Thank you. I think you covered everything. So I'm going to just go to the next slide. So in terms of the examples of VBHC, Imagine Citizen for Health is a grassroots organization developed in Alberta. I believe they have about 700 to 2,000 members, and they've been advocating for patients. So what intrigued me is that they just got funding for a project to get more KPIs or actual patient indicators into the system, such that then the how do you say this? But the greater patient outcome measures will be put part of the system, and so that way it'll shift the attitude in terms of what the prioritization should be and what the funding should go to. And so by next summer, they're going to have a preparation meeting, but that's the plan, is basically get PROs and PROMs into tertiary healthcare KPIs such that they could actually start changing the attitude and get greater visibility on those indicators. I'm going to turn it over to Evan now.
Idamik skinotani niksukuex nistawano kapsipistu nidomtu tu Siksikawa. Good morning, everyone. My name is White Owl, and I am from Siksika Nation, Alberta. I'm a member of the Blackfoot Confederacy, which was also one of the signatories of Treaty 7. I take up the other half of Alberta. So I'd like to take this opportunity to thank my relations, the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples for hosting me in their territory. My English name is Evans Yellow Alderman. I was asked earlier at this conference, at this summit, what Yellow Alderman meant. Growing up, I didn't know what Yellow Alderman meant. I didn't know the story of Yellow Alderman, so I made up a story because folks are inevitably inclined to ask what Yellow Alderman was, and I said that it was an ancestor of mine who had jaundice. Turns out that's not the story of Otukupidaki. Yellow Alderman was actually an ancestor of mine. Her name was Otukopidaki. She was gifted a dream from the old ones to start using yellow paint in ceremony for our people. And when the settlers came over and started giving out English names, Yellow Alderman became her last name, and all her descendants since have been Yellow Aldermans. My English name is Evans Yellow Old Woman. Evans is actually the name of a boy my mom had a crush on in high school, so not as cool of a story. I'm currently the Associate Director of Indigenous Relations at the Alex Community Health Center in Calgary. Some of what I'm going to talk about today is going to make some people uncomfortable. I can assure you it's uncomfortable for me as well. But as we move forward, I encourage you to sit with this. I encourage you to explore this, explore your uncomfortableness, and figure out where it's coming from. I was asked here to speak on the issues Indigenous people face here in Alberta. Now let me preface what I'm going to say with this. I'm here to share my experience and my story only. I'm not the spokesperson, nor am I the representative of the 600 plus First Nations across Canada. Oftentimes in these situations when we have these conversations, we are tokenized, and what we say is then pan-indigenized. Although we share similarities in culture and spirituality, we are all distinct, strong, and sovereign nations. So the systems that we operate within are not built to be inclusive of everyone. Now, what I'm going to say next is probably going to stir the pot, but if we don't talk about it, then the problem is only perpetuated. We need to address the whiteness in our systems. Now, that's a hard pill to swallow. Race and privilege always is. And when I even mention it, it becomes an automatic bone of contention. I often hear, well, I grew up poor, therefore I am not privileged, or I experienced trauma growing up, therefore I am not privileged. Or if I say how tired I am of the system of white privilege that excludes and harms Indigenous and Black communities, some people accuse me of hating on white folks. Now, if you do get upset when someone points out that you have privilege, that probably means you don't fully understand what privilege is. Having privilege doesn't mean that you're a bad person, or that you haven't had struggles, or that you haven't worked hard for what you have. It just means that your skin color isn't a contributing and determining factor to said struggles. And because there are all these misconceptions about privilege, it oftentimes shuts down our opportunities to understand and be accountable for it. We'll never be able to change the everyday ways we all contribute to injustice if we can't talk about our own privilege, if we automatically reject the idea that it exists because we don't understand it. Each of us, yes, even the most disenfranchised, benefits from an identity that benefits from the exploitation of another group. So refusing to face your own privilege helps keep oppression in place. So it's not enough to show up in solidarity and speak out against unjust systems like we are doing here today. What we have to do is within our power to dismantle. We have to do what is within our power to dismantle these systems. We have to change our own behaviors and be mindful that we are not contributing to keeping that system going. Jesse Thistle says, if you are serving 40% Indigenous folks, then your staff should be 40% Indigenous. Representation is so important. If you don't see yourself in the services that you access, you most likely won't access those services. In the city of Calgary, in the Northeast Quadrant, they did an environmental scan of the health centers and found that Indigenous folks represented less than 5% of the patients. The Northeast has the highest population of Indigenous residents than any other quadrant of the city. Now, if my people aren't accessing those health centers for their services, then where are they going? Well, truth be told, they're not going anywhere. That is why we are always 10 times higher than the national average in all of those major at-risk statistics that you see. Why aren't we accessing? Well, we need systems that are built to be inclusive, systems where people belong instead of trying to fit in. We need to be able to talk about whether we are designing our systems for actual progress rather than our own comfort. At my organization, when they hired me back in April, there were a few conditions I had in order to start that work there. Number one, we needed an Indigenous relations team. Number two, there needs to be space for work around decolonizing anti-racist and trauma-informed care embedded with traditional knowledge and autonomy as Indigenous people. We will host community consultations because all too often the decisions an organization makes are made for people who do not have a seat at the table. We will retrain all staff, from board to volunteers, in a cultural safety and trauma-informed care. Once this is complete, the organization will release a statement in which they convey why they are choosing to answer these calls to action and make a commitment to community to answer these calls. We'll create space for folks to access elder support, traditional medicines, and an Indigenous mental health team. We will intentionally recruit more Indigenous doctors, nurses, social workers, and support staff. And we will make sure that all job postings state a knowledge and understanding of the United Nations Declaration on the Rights of Indigenous People and the Truth and Reconciliation Commission's 94 calls to action considered to be an asset. There are massive fundamental gaps in knowledge, understanding, and commitment to making this place better than it is. Speaking specifically about Indigenous folks, there have been hundreds of years of trauma that have been inflicted on us. Not knowing what that history is and the effects of that trauma and how it impedes on the folks that you work with is ultimately a disservice to those folks. And when you don't know what that history is, the possibilities of re-traumatization and re-harm are greater. This would make you and the organization you serve be seen as unsafe. No matter the intent, people and the organizations they represent fail to meet this gap in services, and we will continue to reharm and re-traumatize these folks if we don't do better. The act of decolonizing your services doesn't just benefit the Indigenous people you serve. It benefits everyone. Our systems are too clinical and transactional. We need to introduce the humanity back into our work. You know, I do not share these things to shame or guilt anyone, but the truth of the matter is if you are Canadian, you are benefiting from a system that was intentionally put in place to oppress Indigenous people through means like the Indian Act. I want to remind you folks that Indigenous people are not vulnerable, we are targeted. I often hear the term get over it, or you're just the people who won't pull up their socks, or the Jewish people got over the concentration camps, or the Japanese people got over the internment camps. Number one, never compare genocides, that is disgusting. Number two, usually they have no concept of what it actually is. And number three, with that same logic, the difference is Indigenous people in Canada have never had the opportunity to collectivize and heal as a people. We have never had the opportunity to be like, so that happened. Where do we go from here? And if you truly understood trauma, you would understand that Indigenous folks did not choose to be in this situation that is plaguing our communities. We need allies and we need accomplices within the system. I encourage you folks to read the Indian Act. The Indian Act is the most racist and sexist piece of legislation to ever exist, and we are still governed by that legislation today. Technically, we are still wards of the state. Whatever treaty you are in, I encourage that you read that treaty. It is your responsibility to know because we are all treaty people. I encourage you to read the Royal Commission on Aboriginal Peoples. I encourage you to read the United Nations Declaration on the Rights of Indigenous People. I encourage you to read the Truth and Reconciliation Commission's 94 calls to action. In those documents alone, there are over 1,000 recommendations about how to address this situation. We can't be afraid to start over and build community where everyone belongs. Thank you. Are we done? That's it?
Sorry, I was speechless for a second there. So just have to remember that I'm facilitating. Any questions or comments? You guys did your homework, and you're a hell of presenters. You can use your mics there.
Another.
Okay.
So we had a really interesting conversation at our table yesterday with Evan, and a lot of what he said, he kind of laid it out a bit yesterday, and it was really interesting for me to hear. And it was sparked because of Sharon's presentation yesterday. And while she was presenting, I remembered a podcast that my daughter had shared with me, because I have always said to my daughter growing up, you have to understand that any traumas that you go through as a child are going to impact you for the rest of your life, and they inevitably, the people you meet with as you go through the world have had their traumas, and you have to respect that, and you have to understand that they're going to make decisions, they're going to do things with their lives that are a reaction to dealing with those traumas. So they may not always make the best decisions in the world, and eventually you pay for it somehow. It comes out through interacting with the healthcare community, how healthy you stay. So recently there's this podcast that was put out by this, I think the Attorney General of Health, or the Director of Health in California, who is a black woman. So kudos for her, because she's got like the top job in California. But she has made significant studies and links in trauma and childhood trauma and how it affects society as a whole. And so we were talking about that podcast, and what it means to me is that if we wanted to find one unifying thing, working together as a community, is that the one thing we can all agree, if you cannot own the fact that you're part of the white privileged people of the world and benefiting from that, is that you have to understand that the common denominator is traumas. And if we can all unify on dealing with those traumas, catching them early, so when the child goes to school, we have ways to catch that this person is dealing with a very traumatic situation in her home life or his home life, whatever. We can start to build a society where we address those traumas and we start to take care of those children so that when they grow up, they can be full-fledged, citizens and contributing to the world. And I think that's the unifying thing. And it doesn't discredit or devalue or unrespect. Like, it still shows respect to the traumas that you've had because we didn't do things right, because we were really stupid back then, and we're still stupid. But there's that is the common denominator, the one thing that we can all relate to, and that's where we can start to move forward to build a better system in society.
While you move the mic to Luis, I'm gonna ask a question because I actually stole Chanel's time. So I have a question for Chanel. So how do you propose that we deal with this segmentation of data? Like, how do you think that, what can be a solution to have more collaboration and to have providers communicate to each other and the patient to have agency?
Sorry, okay. So I think this was critical yesterday in asking my questions is data is power, and that data should not reside with the provinces, it should reside with the people. They own the data, they created the data, they're the authors of that data. When it comes to PROMs, PREMs, clinical information, that should reside with the people, and we should have full access to our entire file. And it has to be completely portable. Which means, for example, for all the people here from across Canada that are here in Toronto, if something happens to you, you're going to have to repeat your story because there's absolutely no way a hospital in Toronto will have access to it, even if you come from Ottawa. So part of agency, in today's world, part of agency and being an actor is having your own data. So.
I'm just sort of practical. So I'm just going to ask a practical question. What do you recommend? I mean, I love. What was it we were going to be? No, that's the one. That's the one I want to be. I love being an accomplice. If I can't start a revolution, I at least want to be an accomplice to a revolution. So, what do you think we should do? I mean, other than the obvious things like admitting that we have privilege. Frankly, I'm
so happy I have privilege because I'd be dead if I didn't have privilege, honestly. So, but I just like everybody to have it. I don't want anybody to not have privilege. Just get everybody up there. Maslow's hierarchy. Let's all get to the top of it. Or if I don't even know if you believe in Maslow's hierarchy, but I do.
He actually modeled that after my people, the Blackfoot people.
There you go.
Maslow stole it from the Siksika. He came and studied Siksika people and then used that and said that it was his idea. Siksika.
Okay, so whoever's idea it was, it's a good one. And so the question is, how do you want us to be an accomplice other than what we've done to this point?
I think knowing the history and how it is, history plays a critical role in being an ally. So knowing that history, speaking up, giving platform. So if you have the mic, and there is an Indigenous person with you, give that mic to the Indigenous person, right? Give voice to the voiceless. If you have those, oftentimes what happens is you all have seats at tables that a lot of Indigenous folks don't have seats at. Right? So that's why we need our allies, and that's why we need our accomplices. Learn what an ally actually is, because you can't self-appoint yourself as an ally. That is a right earned from the community. You need to earn that right from the Indigenous community. And we have this saying within the Indian community, sure, you can trust the government, just ask an Indian. We have a lot of mistrust, and rightfully so. There have been, it doesn't matter what the intent, residential schools were a good intention, right? Good intentions pave the way to hell. If you don't know, build that relationship with that community that you want to work with. That old saying, if you build it, they will come, not with the Indigenous community. You need to build a relationship with the folks that you want to work with. What else? Read those documents. I think what happens is a lot of the times folks are like, well, I don't know what to do. Well, those documents that I just read, that I just listed, they have formulas in there. They have the answers to how we're going to address this together, right? I think one thing that folks forget to understand, what they don't understand is when we signed those treaties, it was meant to be a partnership, as was shared yesterday, an equal partnership, and it turned out to be quite an abusive relationship, a paternalistic relationship, right? What's happening now with reconciliation is we're actually forging together the way that this relationship was supposed to have been started from the beginning. So it's gonna be messy. We're gonna screw up. We're gonna make mistakes. It's okay. But that fear that we have as non-Indigenous people, I often hear this as well. Well, I'm just too scared. I don't want to harm, or I don't want to offend anybody by something that I say. I can tell you this, that fear is literally killing my people. Right? We need to step into that fear. We need to embrace it, and we need to get over it, quite frankly. I'll share this little story and then I'll be done. I used to work for this organization. And when we opened up, there were a lot of Indigenous folks that started to hang out in the lobby. Well, the non-Indigenous folks at this agency realized that this was happening and that they were drinking in the lobby. And so the upper-up said, well, there's this group of people, which they labeled the Breakfast Club. And since the Breakfast Club has been around, there has been an increase in drinking and fighting within our lobby. And this happened at a staff meeting. And there was a lot of fear. These people were literally sitting in our lobby for about 6 months. Nobody approached them. And so I asked, well, let's call a spade a spade. You mean the Indigenous folks that are sitting in your lobby? Why hasn't nobody approached them? So one of the workers actually went to engage with them. It's because of fear, is what they told me. They didn't want to, offend, or there was just a fear with engaging with my community. Well, one of them actually stepped out of their shell and went to go talk to them, and what they realized was there were folks within that group that was sitting in their lobby for 6 months where the service providers were looking for them for the past 4 months. They were quite literally sitting feet away. Probation officers were looking for some of these people that were sitting in the lobby for like 3 months, right? And they'd been sitting in that lobby. And this agency was self-proclaimed last stop on the train. So if it's the last stop on the train, then where do my people go if they're not being able to access services at that agency, right? So address that fear, step into it. It's scary. Like I said, this reconciliation business is messy. We're all gonna screw up, but we're forging ahead like we were supposed to at the beginning of the signing of the treaties. So be messy, screw up. Let's work together.
But we in this room, like really, is there one practical thing that we can do ongoing for the next year? I mean, we can read the documents, we can do all that, and that educates us, but then can we do something with
Question
that?
why. Question why we do things the way that we do within our organizations. Like I always, when something happens, or when I'm addressing policy or procedure within my organization, I always ask why 5 times, right? Why do we do it that way? Like, I'm like that kid, I'm like my daughter. Why? Right? So just questioning why. Okay. Because the more that you question, the more you start to realize, oh wait, that policy actually, why do we have that? Why do we have these things? Why do, and we just can't be afraid to burn it all down and start all over again, right? Like that's okay. We have this fear of like letting go. So yeah, just right now, just keep questioning why, read, explore, build relationship with community.
For sure.
Yeah.
And I wonder if you would think this is a good idea, because whenever I get invited to policy consultations, I always ask questions about social determinants of health and whether people are getting the social determinants of health people in the room, not just the privileged. Are you getting the other people in the room? And I think we have to always ask that question, and we always, in my opinion, have to ask whether there has been a consultation with Indigenous populations. Because I'm not the one who's going to tell them what you need, but I can tell them they should go and ask you.
And that's exactly what's been happening, is a lot of decisions have been made for us, right? And I come from a viewpoint of nothing about us without us, right? So, yeah.
Just
Got one here, one here.
So I just want to pivot that in terms of asking why in a different framework of our healthcare system. So Canada is the only country in the top 11 that has a single-payer system where the government has a monopoly on healthcare. Every country that has a universal healthcare system has a hybrid system of private and public, except Canada. So I say this because this is personal. So when my wife was diagnosed with lung cancer, we wanted to get a gene sequencing test. AHS said no. We said they did it a year before, but they said you don't fit the protocol, so therefore you should not receive it. So we had to leave the country for the test. Often you go to the States, not because it's private, it's because it's the easiest to fly there when you're suffering in pain. You have to get on the flight, right? Sometimes you can't fly back, you have to be grounded, you have to drive back. The end result was that test we did in Boston, and she was positive for the latest lung cancer drug approved from Health Canada, but not available and free, but the test was not available. The end result was she was positive for the test, which means positive for the drug. She got the drug and she lived another 18 months. She had 2 months to survive because she had brain and bone metastasis. The government denied her the test that was done in Edmonton a year ago. We got the test done and she lived another 18 months. Right? So my question to like what Evan's saying, different framework, is like why? Why is our system like this? And quite frankly, our systems like this is because we've attached healthcare to Canadian identity. That's my hypothesis. And that Canadian identity is, the part of that is our ego. We do not want to change our healthcare system. Right? So, okay, I'd like to get another opinion, but the thing is, every system, Fair enough. I don't want to speak in absolutes, but the point is we want to change it, but there's a lot of people, especially the healthy, who think we have a safety blanket because of our healthcare system, gives us universal healthcare. Until you go into it, then you realize, wait a second, there's huge gaps.
I'd like to, just from my own reflections, tie a little bit of those two conversations together, which is just as part of a continuation of the dialogue that you guys were just having, it really, give where you're in a position, provide the resources, the power, the voice, etc., directly to the Indigenous partners and communities in your area that are relevant to whatever the conversation or the service delivery agency or whatever it is. Give that power directly to these groups and these individuals to do this work. There are fundamentally different ways of knowing and being by each of these different nations that if we were to be able to understand why we need our privilege and why and the history and that how that continues now, we need to realize that none of this is done. It's all continued through our systems, including obviously our healthcare system, our justice system. It is how we as a culture also think and be. So the more we can understand and critically reflect upon that and start to have a greater appreciation for our sisters and brothers of the First Peoples of these territories, the more we can also, the symptoms that are being listed, the problems we're discussing in our system are very specific to the way we think. And if we were to give more power and to be a little bit more quiet in rooms and to listen to the cultural viewpoints and the different ways of thinking and being of our brothers and sisters of the First Peoples of Turtle Island, we would begin to learn and think of different ways of not just working together and working in our own areas, but in how we can transform healthcare. So these are all symptoms, right? So when we're talking about the siloing, and there's interconnectedness in the worldviews. You wouldn't develop systems that look like this. So I want to tie a little bit these conversations together because I think it's really important for us to be more humble as a culture and to give more power to it. I'm going to use the broad language of Indigenous peoples in Turtle Island so that we can actually begin to make some real fundamental shifts. And so all of that critical reflection is really important, and it will solve the symptoms that we see in our system.
So we'll talk more about this at lunch. Right? Just 2 quick points. In Alberta, there's also a law that says you can't have more than 1 bone marrow transplant, crazy as it sounds. So there were some, in the early days of CML, there were some patients who obviously failed treatment and had to go for a bone marrow transplant. And the first bone marrow transplant didn't work, and they needed a second bone marrow transplant, but the government of Alberta said, nope, sorry, you only get 1 kick at the can. So a lot of my early years in CML was actually getting people from Alberta to come to Quebec, and Saskatchewan also has the same law, and it hasn't changed, to come to Montreal and get their second or third or fourth bone marrow transplant. And many of those people survived. It took 3 or 4 bone marrow transplants, if you can imagine. But they are alive. They are alive. Can you imagine? That's one thing. That's really, it has to change. I mean, the other thing is what can we do, Evans? I just realized, why don't we all go out and look for the Indigenous patients that have our disease and make sure we're giving, I'm sure there's, and it's, listen, here's privilege speaking, Evans. I have not met an Indigenous person who has CML, but I'm sure they're out there. And I've done surveys. I've traveled across Canada. I've gone everywhere looking for patients, but those people don't come because why would they come? What am I doing to bring them in? Another thing on privilege, I had the privilege of being friends with a Rockefeller and a Desmarais. And I got them privately over a glass of wine and I said, what's it like being you? Because I have no concept of being a billionaire. And they got very brutally honest with me and they said, do you want to know something? I have no regrets. Who I am, where my money came from, my family, it has bought me everything. And when I look upon people who don't have what I have, I feel deep sorrow because I think everybody should have what I have. And it was pretty interesting to be able to have that kind of conversation with somebody. And it goes to what Louise was saying. I think that's what we need to do. We need to lift up everybody and not, I don't want to equalize. I think we need to lift up.
Can I just say the one good thing about our flawed healthcare system is that everyone in this room is in this room today. And you all know my story. I was dead and gone in 2003, 2006, 2007. I had to pay for my drug, bring my drug in from the U.S., leave BC to go to Alberta to get it. It was like crazyville because we live thinking we have this incredible healthcare system, and it's still not working for me. I am now the longest survivor of melanoma in North America, and I don't even know where I exist. Somebody said yesterday, I heard a comment, I feel like I live in a country with no map. And we truly do. But the one good thing that's come from this is all of this. And what I've learned over the last 10 years from having this foundation has been incredible. The people I have met, like everyone in this room, that has a passion and a mission and a goal to change this, I truly believe we can. And people always say I was left here for a reason. I say it's because he only takes the good ones, and I'm not. And but I think that's the good in all of this, is that we get to hear from people that we need to hear from, and I think that's the beauty of this, if there is one.
And I love to see BC and Alberta getting along.
We can't separate without the Indigenous folks, so we say no.
Thank you so much.